Hello, my name is Dan Filardo, and I'm a medical officer with the CDC, and today we'll be talking about a clinical overview of measles, diagnosis, laboratory testing, and outbreak response. These are our standard disclosures. So the objectives of today's talk are to differentiate the clinical presentation of measles from other viral causes of a febrile rash, to discuss the laboratory diagnosis of measles and how to optimize the use of laboratory testing, recognize the importance of measles vaccination, describe measles outbreak response in a clinical setting, including post-exposure prophylaxis, identify one way to improve reporting and the collaborative process to address all aspects of a measles outbreak, and to identify key strategies to best diagnose and test for measles in case of a future outbreak. So let's talk first a little bit about the epidemiology of measles in the United States. Measles was declared eliminated in the US in the year 2000. And elimination means that there has not been any sustained transmission of measles within the US lasting 12 months or more during this time. From 2001 to 2023, a median of 72 cases per year have been reported, ranging from a low of 13 cases in 2020 to a high of 1,274 cases in 2019. The years with the largest number of cases, 2014, 2018, and 2019, were years with large outbreaks. Measles activity around the globe was high during these years, and measles was subsequently imported into susceptible US populations, which resulted in large outbreaks. Declines in measles vaccination rates globally have increased the risk of larger measles outbreaks worldwide, including in the United States. Measles remains a common disease in many parts of the world, causing substantial morbidity and mortality. In 2022, an estimated 136,000 people, mostly children, died from measles. During 2024, many countries and popular travel destinations for US residents are experiencing measles outbreaks, including the UK, India, Austria, the Philippines, and others. In the US, all measles cases originate from international travel, and importations most often come from unvaccinated US residents traveling abroad. So this figure looks at all imported measles cases during 2001 through March of 2024. And since 2001, a median of 25 international importations were reported each year, ranging from a low of 7 imports during 2020 to a high of 92 imports during 2019. And the figure shows the number of importations per year by residents. US residents are shown in purple, and foreign visitors are shown in gray. And overall, 64% of imported cases were among US residents. Since 2022, 70 to 100% of imported cases were among US residents, indicating that there were many missed opportunities for US residents to get vaccinated prior to their international travel to prevent exposure to and importation of measles. Unfortunately, two-dose MMR coverage by the time of school entry has declined in the United States from 95 to 93% during the COVID-19 pandemic. While this is a small absolute difference in terms of percentage, it translates to approximately 250,000 kindergartners at risk of measles each year. Exemptions to childhood vaccinations have risen during this time and are at 3% nationally, with 10 states reporting exemption rates for pediatric vaccines of greater than 5%. This is a really good reminder to all providers about the importance of the routine childhood vaccine schedule and getting everyone up to date on their vaccines. This epicurve shows the confirmed measles cases reported during 2023 and 2024, shown by week. And tracking with global measles activity, we can see a rise in the number of cases seen during 2023, with small numbers and sporadic cases in early 2023, followed by a rise in cases near the end of the year. During 2024, we've seen a more consistent trend of importations of measles, with 10 outbreaks of 3 or more cases during 2024, as of May 23rd. And these data show a little more information about the measles cases reported during 2024. So as of May 23 of this year, 142 cases have been reported. And some of the characteristics, those under 5 years of age represent almost half of all cases, 44%. Those 5 to 19 years of age represent just under a quarter, 23% of all cases. And people aged 20 years or older represent about a third, 32% of all cases. And tracking with our national data since we achieved elimination, most cases have been among those who have been reported to be either unvaccinated or have an unknown vaccination status. So far this year, that's been 82% of all cases. 13% of cases have had a documented 1 MMR dose prior to infection, and 5% of cases have had documentation of 2 MMR doses. So for our first knowledge check, measles cases in the U.S. are most commonly the result of virus importation by unvaccinated foreign visitors. True or false? And the answer is B, that's false. Most importations are related to unvaccinated residents who travel abroad and return home with measles. So let's discuss some clinical aspects of measles. Measles is an acute febrile rash illness caused by measles virus. It is transmitted by direct contact with infectious droplets and can also be spread by the airborne route. And measles is highly contagious. 90% of susceptible household contacts will develop illness if exposed to a measles case. And the estimated reproductive number, or R0, is 12 to 16 in an unvaccinated population, meaning that a measles case would be expected to result in 12 to 16 secondary cases if all contacts were unvaccinated. So measles presents with a high fever, up to 105 degrees Fahrenheit or 40.5 degrees Celsius, and a rash, which we'll talk about shortly, and one of the 3 C's, which includes cough, coryza, or runny nose, or conjunctivitis, or some combination of the 3. The fever is present when the rash starts, and the fever often peaks around the time the rash starts or after rash onset. And according to the Council of State and Territorial Epidemiologists, or CSTE case definition, fever, rash, and one of the 3 C's must be present to be considered a clinical measles case. The measles rash is generally described as starting on the face, at the hairline or behind the ears, and then subsequently spreading downwards to the neck, trunk, and extremities. The rash is maculopapular, being made up of small, raised, or flat bumps. As the rash progresses, these spots may join together or coalesce. The rash is not usually itchy, and if pruritus is described, it's generally considered pretty mild. Koplik spots may be present as small white papules on the buccal mucosa. These can appear before or at the same time as the rash, but they are hard to see and not always present. And the rash can present atypically in people with immunocompromising conditions and in people who have been previously vaccinated against measles, but overall the presentation I've described here is pretty consistent among unvaccinated cases. So one thing to note is that the measles rash may be difficult to see depending on the patient's skin tone. So the maculopapular rash may be more difficult to identify on darker skin tones. The redness may not be as evident. The skin may appear hyperpigmented as opposed to red or erythematous with darker or purple macules and papules. And the rash, as it progresses, can progress to scarring with hypopigmentation. So to illustrate that, we can look at measles rash on different skin tones. On lighter skin, the rash redness is pretty clearly visible. However, the redness may be less apparent on a darker skin tone, as seen in the middle picture. And finally, on the right photo, on darker skin, the rash really may be difficult to see if looking only for redness or erythema. You may not appreciate much of a rash at all. And the most prominent sign may be the papules, as seen here on the forehead. So timeline is a very important piece of the history of illness to obtain when suspecting measles. So let's review the typical timeline one would expect. After exposure to the measles virus, there is an incubation period of on average 10 to 14 days, during which time the exposed person is asymptomatic. Around 2 to 4 days before the onset of the rash, the prodromal symptoms begin. And this includes the fever and at least one of the 3 C's, that's cough, coryza, or conjunctivitis. And following these prodromal symptoms, the rash begins. The date of rash onset is considered day 0, and a person with measles is considered infectious from 4 days before to 4 days after the rash onset. So on average, the time from exposure to developing the rash is about 14 days, but the incubation period can range from 7 to 21 days from shortest to longest. The most common measles complications are diarrhea, otitis media, and pneumonia. And these occur in less than 10% of cases, but they can cause substantial morbidity, especially measles pneumonia, which can cause severe disease in infants and immunocompromised people. Complications can result in hospitalization, which occurs in about 1 in 5 cases, or 20% of the time. And this is primarily for dehydration and pneumonia. And other severe but less common complications include encephalitis, which occurs in about 1 per 1,000 cases, and death, which occurs in about 1 to 3 per 1,000 cases. Complications are most common in children under 5 and adults over 20. And complications are also more common among those who are unvaccinated against measles. Subacute sclerosing panencephalitis, or SSPE, is another complication to discuss. It's a rare but devastating neurologic complication that occurs a median of 7 years after measles infection and is more common for those who developed measles at less than 2 years of age. It's a syndrome of progressive neurologic decline, which is uniformly fatal within 1 to 3 years of onset. And estimates of how common SSPE is can vary depending on the report, but data from California, published in 2005, suggests that it occurs in about 7 to 11 per 100,000 cases of measles. So notably, MMR vaccine does not cause SSPE and has been shown to protect against this complication. To briefly review measles treatment, there is unfortunately no well-studied and efficacious antiviral therapy for measles. There is a therapeutic role for vitamin A in some cases. Vitamin A deficiency, while rare, can lead to a higher risk of complications and delayed recovery from measles. And vitamin A supplementation can help prevent measles complications, although data on the efficacy of supplementation are mixed, and not all studies showed improvement with supplementation. In general, CDC recommends vitamin A supplementation for hospitalized children. Measles virus is susceptible to ribavirin in vitro, but data on its clinical use and efficacy are extremely limited. Ribavirin could be considered in consultation with an infectious disease expert for patients with severe measles complications or for immunocompromised patients. Adding to the challenge of recognizing and diagnosing measles, there are other viral causes of a maculopapular febrile rash, and I've listed here some of the most common. So first, parvovirus B19 causes what is known as fifth disease, which can present with fever and a quote-unquote slap cheek rash, which is shown in the top photo, where a rash begins on the cheeks and can then spread to the trunk and extremities. This infection is more common in school-aged children than in infants. Human herpes virus 6, or HHV6, can cause a viral illness known as roseola, or sixth disease. HHV6 can cause a similar disease course to measles with a constitutional prodrome, followed by a maculopapular rash, although for roseola, the rash generally resolves more quickly than it does for measles. And the fever in roseola usually peaks and often resolves prior to rash onset, in contrast to measles, where the fever peaks around time of rash onset and definitely continues through onset of the rash. Enteroviruses can cause a fever and rash with a similar rash pattern to measles, although the rash with enteroviruses can present in many different ways, including with urticaria, which would not be consistent with measles. The most common syndrome that can mimic measles is hand, foot, and mouth disease, an example of which is shown in the bottom photos. But this typically affects the palms of the hands and the soles of the feet, whereas measles rash does not generally appear in these places. And finally, a maculopapular rash can be seen related to antibiotic sensitivity reactions or antibiotic allergies. So to review a clinical summary, measles is an acute febrile rash illness caused by the highly infectious measles virus. There's an asymptomatic incubation period of about 7 to 21 days between exposure and rash onset. The infectious period lasts from 4 days before to 4 days after rash onset. Complications of measles can include hospitalization, diarrhea, otitis media, and pneumonia, and complications are more common in younger children and adults. And there is no specific antiviral agent for measles treatment, but CDC does recommend vitamin A supplementation for all hospitalized children. So knowledge check number 2. What is the typical presentation of a measles rash? Is it A, does it starts on the trunk and spreads up to the hairline and extremities? B, starts on the extremities and spreads everywhere on the body, including the palms and soles? Or C, starts at the hairline or face, then moves down to the trunk and extremities? We can see the answer is C. Starts at the hairline or face, then moves down to the trunk and extremities. So let's talk about measles prevention via vaccination. The measles vaccine was first licensed in the US in 1963, and combination MMR vaccine was licensed in 1971. MMR is an attenuated or weakened live virus vaccine. The vaccine cannot cause measles and cannot be transmitted from person to person. However, transient side effects can occur which can mimic measles. MMR vaccination is highly effective. It's estimated that a single dose provided at the typical schedule, which in the US is after 12 months of age, is about 93% protective against measles, and 2 doses provide about 97% protection. MMR also has an excellent safety record, and we'll discuss vaccine side effects in a few slides. According to the typical pediatric vaccination schedule, a first dose of MMR is given between the ages of 12 to 15 months, and a second dose is given between the ages of 4 to 6 years before school entry. A dose before 12 months of age can be given if needed to provide protection, either during international travel or during an outbreak response. And if a dose is given between 6 to 11 months of age, 2 more doses should be given on the usual schedule. MMR vaccine recommendations for adults take prior immune status into consideration, as adults may have been vaccinated or infected with measles previously. Adults are considered to have presumptive evidence of immunity if they have written documentation of receipt of MMR vaccine or any other measles-containing vaccine. And that can be 1 or 2 doses depending on the situation, and we'll talk about that. They can also have presumptive evidence of immunity if they were born before 1957, if they have laboratory evidence of immunity, that is a positive IgG on a blood test, or if they have prior laboratory confirmed measles. And it's important to note here that a clinical diagnosis of measles alone is not sufficient, partly because of the measles mimickers we discussed previously that could provide a false reassurance about future measles immunity. So adults generally are considered to have presumptive evidence of immunity if they have 1 documented dose of MMR. And adults without other evidence of immunity generally should get 1 dose of MMR. 2 doses, however, are required or recommended for adults at high risk of exposure or those in settings where the risk of transmission might be high. So this includes healthcare personnel, adults who will be traveling internationally, and post-secondary school students, which includes all schooling after high school. So let's talk a little bit more about international travelers. CDC recommends that all U.S. residents older than 6 months of age who will travel internationally receive MMR vaccine prior to departure if they are otherwise without evidence of immunity. And this is different than the routine schedule, which starts at 12 months of age. So infants 6 to 11 months of age who will travel internationally are recommended to get 1 dose of MMR vaccine before travel, and ideally 2 weeks before travel to allow for immunity to take hold, although the vaccination can be given closer to travel if needed. And as we discussed, this should be followed by 2 more doses on the typical pediatric schedule. For children 12 months of age or older, 2 documented doses of MMR vaccine in total are recommended, separated by at least 28 days. And as for teenagers or adults without evidence of immunity, this also is a recommendation for 2 doses of MMR vaccine, separated by at least 28 days. There are some contraindications to MMR, which are related to it being a live virus vaccine. The main contraindications are severe immunocompromising conditions, including hematologic malignancy, receipt of chemotherapy, and long-term immunosuppressive therapy. And this includes HIV if the CD4 percentage is less than 15% or absolute CD4 count is less than 200. And family history suggestive of a congenital immunocompromising condition unless assessed to be immunocompetent by a clinician or laboratory testing. And a history of severe allergic reaction to MMR or to an MMR vaccine component. Of note, egg allergy is not a contraindication to MMR vaccination due to a good safety record of MMR vaccination in this population. However, people with any severe life-threatening allergies, such as anaphylaxis, should talk with their healthcare provider to ensure it is safe to get MMR. And finally, MMR should not be given to pregnant women. There is additional information at the CDC website listed at the bottom of the slide about MMR vaccination. Adverse events due to MMR vaccine are rare. As we discussed, MMR has a really excellent safety record. Common side effects include fever, which occurs in less than 15% of recipients, a brief rash, which occurs in less than 5% of recipients, and lymphadenopathy, which is more common in adult recipients than in children. Rare serious adverse events occur, but they are infrequent. Anaphylaxis occurs in approximately 2 to 14 events per million MMR doses given. Febrile seizures occur in 1 event per 3 to 4,000 MMR doses, and a low platelet count can occur in 1 per 40,000 MMR doses given. And this low platelet count is often transient and carries no complications, but there can be a greater risk for this to happen if someone has a known diagnosis of idiopathic thrombocytopenic purpura, or ITP. So one thing to highlight here is that MMR itself can cause a self-limited rash, which is not contagious to others, and which is generally shorter in duration than the rash caused by wild-type measles infection. The photo on the right, which was a rash that was confirmed by testing to be a reaction to the MMR vaccine, shows that in some cases this rash can be indistinguishable from the rash of a measles infection. Rashes that mimic measles after MMR are pretty rare, but worth knowing about, and management of a vaccine-associated rash really doesn't require anything other than supportive care. However, differentiating measles from an MMR reaction in the setting of an outbreak can be challenging, especially if MMR was given as post-exposure prophylaxis, which we'll touch on later. So if a clinician is concerned that a patient has been recently vaccinated, but also has risk factors for measles infection, like a known exposure or recent international travel, they should definitely reach out to public health in their jurisdiction to discuss the case and see if additional testing is needed. So let's talk a little bit more about the laboratory diagnosis of measles. These days, most U.S. measles cases are tested and confirmed by RT-PCR, which is reverse transcriptase polymerase chain reaction testing, which is typically performed on NP or nasopharyngeal or OP or oropharyngeal swabs, but can also be detected in the urine. Urine testing by RT-PCR can be done, but generally in conjunction with an NP or OP swab. Specimens are ideally collected within 3 days of rash onset for optimal sensitivity, but they can be positive for up to 10 days after rash onset. And it's best to collect specimens for RT-PCR as soon as possible after rash onset to optimize detection. Proper specimen collection, storage, and processing are important to maintain the stability of viral nucleic acids and maintain the integrity of the test. RT-PCR has a much higher sensitivity and specificity than serology, which we'll talk about on the next slide. And false positive results can occur, but they are much less common than occurs for serology. And CDC and state public health labs can perform RT-PCR testing for measles. So let's talk a little bit more about measles serology. Measles can be diagnosed by detection of measles-specific IgM, or immunoglobulin M, and CDC does recommend performing serology alongside RT-PCR. IgM is produced starting usually 1 to 3 days after rash onset, but it can be detected for up to 6 to 8 weeks after rash onset, so it can definitely expand the window for a measles diagnosis compared with RT-PCR. IgG appears a few days after IgM and should be reliably detected 7 to 10 days after rash onset. And just a note here that if a provider is interested in knowing whether or not a patient is immune to measles, testing for IgG alone is appropriate, and testing for IgM should not be performed. However, it's important to note that use of IgM alone can pose challenges in settings with low measles incidence, like in the US, where we have maintained elimination. First, cross-reactivity with other causes of febrile rash illness has been documented, especially with HHV6 and parvovirus, which, as we discussed, can mimic measles and cause a febrile rash illness. And second, false positive results are relatively common when the likelihood of measles is low. For example, in a case where there isn't local active transmission and patients have not traveled internationally, and when patients without known exposure have been fully vaccinated. So laboratory results for rare diseases always need to be interpreted in the clinical and epidemiologic context, which is basically another way to define how likely it is that a person actually has measles before you even run the test. So for example, for clinical context, we can ask, has the case been previously vaccinated? We know that 2 doses of MMR are highly protective, although there are vaccine failures and breakthrough cases occasionally, but previous vaccination makes it less likely that a person has measles. Another question is, are the symptoms consistent with measles? Maybe the rash doesn't fit the typical characteristics. And finally, is there another potential cause for the clinical presentation, such as another cause of fever, or a clear alternative cause of the rash, such as cellulitis? From the epidemiologic context, we could ask other questions that inform how likely it is a person has measles. Is there known measles transmission in the area where this person is living, or a known exposure? And has this person traveled, either domestically or internationally, to a region with ongoing transmission? These features would raise the pretest probability and reduce the risk of false positive testing. So at a glance, and to summarize, clinical, epidemiologic, and laboratory data should all be considered when diagnosing measles infection. Second, using serology alone, in this case IgM, to test patients with a low pretest probability of having measles will result primarily in false positive results. And third, both serum and a nasopharyngeal or oropharyngeal swab should be collected for all suspect cases of measles. So let's do our third knowledge check. What testing is recommended for measles diagnosis? Is it A, measles IgM only? B, a swab from the nasopharynx or oropharynx for RT-PCR only? C, both serology and a swab for RT-PCR? Or D, none, measles is a clinical diagnosis? And as we discussed, the answer is C, both serology and a swab for RT-PCR. So let's talk last about some aspects of the measles response that impact bedside clinicians. So one key piece of any measles response is to accurately identify cases and establish the diagnosis. And as we've discussed, establishing the diagnosis relies on interpreting the combination of clinical and epidemiologic data, as well as laboratory testing. And at the bedside, there are some important pieces of history that can help determine whether or not there should be concern for measles. First, does the person meet the clinical case definition? As we recalled, this is fever and rash and at least one of the 3 C's, that is cough, coryza, or conjunctivitis. Second, what is this person's vaccination history? Have they received doses of MMR in the past? And finally, is there any known travel, such as international travel, where a person might have been exposed to measles? Or is there domestic travel within the last 21 days to a place in the US where measles is known to be circulating? And finally, is there any known exposure to measles in the last 21 days, such as in the household, in an educational setting, or another place? Another part of measles response is to report both suspect cases and confirmed cases of measles to public health authorities. Healthcare providers in many jurisdictions are required to report suspected measles cases to their local health department. Reporting requirements may vary by jurisdiction. And I'll make the case that public health departments can really help early on in a measles investigation for bedside clinicians. So public health departments can help advise on the need for testing, and because most testing is done for RT-PCR through public health laboratories, public health departments can help advise on the appropriate routing for specimens. And early involvement of public health departments can really help prevent measles outbreaks through early contact tracing and early provision of vaccination and other efforts for outbreak mitigation like post-exposure prophylaxis. If an outbreak is declared, clinicians and the health department can work together to identify and prioritize susceptible contacts to measles cases. Those without presumptive evidence of immunity are at high risk to develop measles. Exposed persons who are at higher risk for severe disease include infants less than 1 year of age, pregnant women, and people with immunocompromising conditions or taking immunocompromising medications. So one component of outbreak control is post-exposure prophylaxis, or PEP. And PEP would be done in coordination with public health authorities who are doing a measles contact investigation. But there are some things that it might be helpful to know clinically about the options. So there are two options that are available for PEP, MMR vaccination or immunoglobulin. And PEP within the target window with either modality may provide protection from measles or modify the clinical course of disease among susceptible people. So MMR vaccine should be given within 72 hours or 3 days of the initial measles exposure to be considered effective as PEP. Vaccination can be given after this window, but would only be expected to protect from future exposures and is not considered adequate PEP for the measles exposure at hand. Immunoglobulin needs to be given within 6 days of initial exposure and can be given intramuscularly, that is IMIG, or intravenously, that is IVIG. And IVIG should be prioritized for adults at high risk of severe disease. So that includes adults who are pregnant and adults with immunocompromising conditions. Another control measure is to isolate patients with measles while they are infectious. So recall that people with measles are considered infectious for 4 days before and 4 days after rash onset. Measles shedding typically drops off fairly rapidly after the rash onset for people without immunocompromise. Unfortunately, people with immunocompromising conditions or taking immunocompromising medications may require more prolonged isolation, given the possibility that they can shed measles for longer. And isolation should be tailored individually in that case, usually with the assistance of public health authorities. And finally, a few notes about healthcare settings. Providers can help prevent spread of measles in these settings if a suspect case is identified, by first encouraging people suspected to have measles to contact the healthcare facility before arrival if they are known to be a suspect case. Second, to provide the patient a face mask if they are old enough to wear one, and promptly isolate the patient in a room with the door closed to prevent exposure to others. And third, to implement standard and airborne precautions as soon as possible in an airborne infection isolation room, or AIIR if available. And if no AIIR is available, such as might happen in a clinic, a single room with a closed door away from possible susceptible contacts is appropriate. And another control measure is community vaccination to prevent outbreak spread. So if preschool-age children are at risk due to a measles outbreak location and transmission setting, a second dose early between the ages of 1 and 4 years could be considered. And this would be a second dose before the typical second dose is given according to the routine schedule between 4 to 6 years of age. And adults in these settings, such as daycare settings or other educational settings, could be considered for a second dose at least 28 days after any prior dose if they've only received one dose previously. And if infants less than 12 months of age are at risk, an MMR dose for infants aged 6 to 11 months could be considered. But as we've discussed, repeat vaccination should be pursued for these infants according to the routine schedule, that is, with another dose between 12 to 15 months of age and another dose between 4 to 6 years of age. So just to review, in collaboration, clinicians, public health authorities, and community partners can exercise control measures to prevent the spread of measles. First, identify probable and confirmed measles cases with an emphasis on the clinical criteria to identify those with high risk for measles who require further testing. Next, clinicians should report suspect cases to public health to get them involved early and coordinate testing. Next, provide PEP for susceptible contacts at high risk of severe disease to prevent morbidity of measles. Next, clinicians and public health departments can prevent the spread of measles at healthcare facilities with early identification of suspect cases. And lastly, vaccination should be pursued to prevent community spread of outbreaks. So with our last knowledge check, what key activities during a measles outbreak are carried out in collaboration between public health authorities, community organizations, and medical providers? A, identification of cases and appropriate testing. B, reporting of suspect and confirmed cases. And C, implementation of control measures, including vaccination. Or D, all of the above. And the answer is D, all of the above. So that concludes our talk. Here are some resources available to healthcare providers and to public health professionals. And on this slide, we have some resources for clinicians regarding measles vaccination questions and addressing questions about vaccine hesitancy. So we'll end with a recent ad campaign from the CDC. It says, she thinks measles are used for drawing in art class. Childhood vaccinations keep it that way. We've maintained elimination of measles in the United States since 2000 due to our strong vaccination program. And let's keep it that way. Thank you.